Hello doctors, today we are here with another topic of pediatric surgery, that is duodenal atresia. In previous topic of pediatric surgery, I have already told you about the infantile hypertrophic pyloric stenosis. So we will continue today with the next part, that is duodenal atresia. So one of the most common cause of neonatal intestinal obstruction is duodenal atresia, and the first case was reported in 1733. And this duodenal atresia is most commonly associated with Down syndrome, and the incidence is 1 in 6,000 to 10,000 births. Therefore, that is not so common. More common is infantile hypertrophic pyloric stenosis. Now, obstruction. Duodenal atresia means we have esophagus, then we have the stomach, then we have the duodenum. Fine. When there is, this is stomach and we have duodenum. When there is obstruction in the duodenum, either in the first part or second part or anywhere in the duodenum, then we call this condition as duodenal atresia. And when there is obstruction in the pylorus, then we call it infantile hypertrophic pyloric stenosis. So know the difference, just basic things. So the obstruction, now obstruction can be intrinsic, that is inside, or obstruction can be extrinsic, that can be outside. Intrinsic obstruction means inside duodenum. So inside the duodenum there is atresia or stenosis, or there is a duodenal diaphragm, or there is a perforated diaphragm, or there is a windshock web. Webs are present. Because of that, food cannot pass and atresia has occurred or obstruction has occurred. Extrinsic thing is annular pancreas. You know about the annular pancreas. Annular pancreas, as you know, the pancreas have a dorsum arising from the dorsum mesogastrium, and pancreas also arise from the ventral mesogastrium. And the ventral mesogastrium rotates and come to this side. And therefore, the final picture of the pancreas is like this. This is the part of the ventral mesogastrium, and the rest of the part is the dorsal mesogastrium. If the rotation is not smooth or complete and there is annular pancreas, this side also and this side also, the pancreas is annular, therefore the pancreas will push the duodenum and this will cause duodenal obstruction. So this will also cause duodenal atresia. The one extrinsic cause is annular pancreas. Second is malrotation of gut, and third is pre-duodenal portal vein. If present, that might also cause duodenal atresia. So these are the causes of duodenal atresia. Now we have to know the embryology also. First, the gastrulation starts in 3rd week and gastric tube formation starts in 4th week. And when the gastric lumen is forming, there is obliteration of gut lumen. Gut lumen is not canalized. So obliteration of gut lumen is around 6th week. But in 8th to 10th week, after obliteration, there will be recanalization. There will be recanalization of the gut in 8th to 10th week. But in cases of duodenal atresia, the failure of process of recanalization, the obliteration of gut lumen continues. There is no canalization. Therefore, there is duodenal atresia occurs. So this is the most important one, that is failure in the process of recanalization is the most common cause of duodenal atresia. Now, pathology, as I have told, number one is error in recanalization as mentioned earlier, and there might be developmental errors also associated with it, and 50% of patients will have other congenital anomalies also. These are the etiologies. There might be genetic etiology. You have to know this, you will read this many times, that is sonic hedgehog gene. So sonic hedgehog gene is a signaling molecule. It is essential for development. Signaling molecule essential for embryonic development, and it plays a key role in pattern formation. Like it is very important for cell growth, specialization and normal shaping of the body, particularly brain, spinal cord, eyes, limbs, gut. These are important. So sonic hedgehog gene, if there is an abnormality in this gene, there might be duodenal atresia. So remember this is a signaling molecule gene. And there might be fibroblast growth factor 10 deficiency, which will also cause duodenal atresia. The associated anomaly I have told in the starting of this video is that most common associated anomaly is the Down syndrome, and remember, approximately 28%. And then the second one is annular pancreas. As I have told, annular pancreas is an extrinsic cause of duodenal atresia. So annular pancreas, 23% of them are associated with it. Apart from that, there may be congenital heart disease, malrotation, esophageal atresia, tracheoesophageal fistula, anorectal anomaly, or genitourinary anomaly may be present with duodenal atresia, but most common is Down syndrome. Now, classification. The classification that we have, this might be new for you and it is important for NEET SS exam. So duodenal atresia is classified by Gray and Skandal-Kallis. Type 1, type 2 and type 3. Three types are mainly present. You have to just know the type and it is very easy. First is that this is the stomach and this is the duodenum. After the duodenum, there is a web present, and web is present in type 1. In type 1, we have duodenal web, and this web is made up of mucosa and submucosa. Just remember this. This web is made up of mucosa and submucosa. Muscle is normal. Fine. The muscle is normal. The mucosa and submucosa forms the web. Muscle layer is normal. And the yellow color, I have denoted this yellow color for mesentery, and mesentery is intact. So type 1 is web formed by mucosa and submucosa with no defect in the muscle coat. And a wind shock deformity may occur if the web is thin. Base of the membrane is in second part of duodenum. These constitute 92%. The most common type of duodenal atresia is type 1. This is the most common type, that is 92% of cases the web is formed from mucosa and submucosa. Type 2. Now in type 2, look the diagram first. In type 2, the two ends are atretic. The two ends are atretic, but these ends are attached by a cord. Fine. And the mesentery, the yellow color is denotes the mesentery, and the mesentery is intact. There is no defect in the mesentery. This is type 2 duodenal atresia, which is 1%, seen in 1% of cases. Look, type 2 is a duodenal end are atretic, separated by some distance but attached by a cord. Mesentery is intact, and this case occurs in 1% of type of duodenal, 1% in population, those who have duodenal atresia. And type 3 is this one. Type 3 is ends are atretic and they are not attached by a cord, and there is a V-shaped defect in the mesentery. In previous two, type 1 and type 2, there was no defect in the mesentery, but in type 3 there is defect in the mesentery, and this is present in 7% of cases. So duodenal ends are atretic, separated by some distance but without any tissue intervening them, and mesentery has a V-shaped defect. So this is the classification for duodenal atresia, type 1, type 2 and type 3, and you can easily remember them. And most common is the type 1. Now you have to know one thing. In my previous video, I have already told that in infantile hypertrophic pyloric stenosis, the child will have non-bilious vomiting, and the vomiting will start in second to fourth week of gestational age. But in cases of duodenal atresia, mostly it is bilious vomiting. But why bilious vomiting? As you can see here in the picture, this is the pancreas, this is the pancreatic duct, the main duct of Wirsung, and accessory duct of Santorini. The above one is the accessory duct of Santorini, and this is the main duct of Wirsung, which is getting attached to the common bile duct. This is the right hepatic duct, left hepatic duct, common hepatic duct, cystic duct, common bile duct, and the pancreatic duct opens into the ampulla of Vater, and this ampulla of Vater is present in the second part of the duodenum. Remember this. And in the duodenal atresia, DA means duodenal atresia, the site of obstruction is in generally D1 or D2, most commonly in D2. Duodenal atresia obstruction generally occurs distal to the ampulla of Vater, As obstruction is occurring distal to the ampulla of Vater, when the infant child takes food, the food as the ampulla reaches up to this area before the obstruction, and this gets mixed with the bile. Therefore, there is a bilious vomiting in duodenal atresia. But in some cases, approximately in 20% of cases, there might be obstruction in the part 1 of the duodenum. Duodenum have 4 parts: D1, D2, D3 and D4. So if there is an obstruction in D1, means the obstruction is proximal to the ampulla of Vater. So if the child is taking food, the food is not reaching up to the ampulla of Vater, so it is non-bilious. Bile is not mixed with it. So remember this, in 20% of cases, there might be non-bilious vomiting in cases of duodenal atresia. So if there is a preampullary obstruction, ampullary means ampulla of Vater. If there is preampullary obstruction, 20% of cases will have non-bilious vomiting in duodenal atresia. Just remember this, very important. Now, clinical presentation. Antenatal detection with fetal sonography, mostly in the second trimester via the fetal sonography, we can know whether the child have duodenal atresia or not. Maternal polyhydramnios is present in 30 to 60% of cases, and vomiting starts from day 1. It is very, very important. Day 1, from the first time the child feeds, the vomiting will occur, because in congenital hypertrophic pyloric stenosis, which is changed to infantile hypertrophic pyloric stenosis, I will give the link of that video in my description because it is important to know. In infantile hypertrophic pyloric stenosis, the atresia is not congenitally present. It develops later on in pylorus. But in cases of duodenal atresia is present from birth only. Therefore, there will be vomiting from day 1. So vomiting starts from day 1, and repeated bilious vomiting will be present. Occasionally there might be non-bilious vomiting. There will be epigastric fullness, dehydration, weight loss, and there will be electrolyte imbalance present in cases of duodenal atresia. The diagnosis is via the plain X-ray. I have told this many times. In duodenal atresia, we have the double bubble sign. This is the double bubble sign. Double bubble sign seen in duodenal atresia, and single bubble sign is seen in infantile hypertrophic pyloric stenosis, and triple bubble sign is seen in jejunal atresia. Fine. So the most important differential diagnosis is malrotation and annular pancreas. Either there may be associated with malrotation or there is annular pancreas, because of which there is an duodenal atresia. So we will do X-ray, and X-ray, if we see the double bubble sign, we will know the patient will have duodenal atresia. Apart from that, we can do USG and upper GI contrast study and CT scan to further confirm the case. In treatment is, this is not a surgical emergency. First, the resuscitation is done. RT insertion, Ryle's tube insertion is done, optimization of any kind of electrolyte disbalance is done. Then what will we do? We will do duodenostomy, that is Kimura type of duodenostomy, which is a side-to-side anastomosis. Open, we can do it open procedure or in laparoscopic procedure also. Here you will see if there is atresia in the duodenum. This is one segment of the duodenum. This is the second segment of the duodenum. There, if side to side means we will give an incision here and we will give an incision here. We will give 2 incision like this. If we have done anastomosis from here and here, then it will be end-to-end anastomosis. And we are giving an incision in the side, and then we are giving an incision this side. This is means side to side anastomosis. The 2 incisions are given. Then via the sutures, they are approximated to each other. After suturing the posterior layer, then the anterior layer is closed. So this is a side-to-side duodenostomy Kimura procedure done in cases of duodenal atresia. So remember, this is the name Kimura procedure, and remember it is a side-to-side anastomosis. Now, post-operatively, enteral feeding from the trans-anastomotic feeding tube is started within 24 to 48 hours. So what is trans-anastomotic feeding tube? Trans-anastomotic feeding tube means we have esophagus, then we have the stomach, and then we have the duodenum. Suppose here we have done the duodenostomy. Fine. Now after, during the OT, from the mouth or nose, we introduce an RT, Ryle's tube. It passes from the esophagus, goes to the stomach, goes to the pylorus. Then we cross this anastomotic junction and place the Ryle's tube here. This is trans-anastomotic, like distal to the anastomotic site. Then we can start feeding. We can give milk from the Ryle's tube or water from the Ryle's tube, and we can start the feeding. And this, what is the importance of this? This Ryle's tube is going beyond the anastomotic site, so this anastomotic site will be dry and it have time to heal, plus we can feed the neonate also. So this is enteral feeding is started from trans-anastomotic feeding tube within 24 to 48 hours, and there might be feeding intolerance which will cause megaduodenum. There will be swelling in the duodenum, that is megaduodenum. Outcome is survival is increased from 45 to 95% now because of more surgical efficacy, and improved diagnosis and better perinatal care is given, and feeding adaptation takes some time. Mortality is related to the associated anomaly. In general, the duodenal atresia if there is isolated duodenal atresia, it has a very good prognosis. If duodenal atresia is associated with Down syndrome or cardiac anomaly or anorectal malformation, then the chances of mortality increases. Therefore, mortality is related to the associated anomaly. Thank you for watching, guys. Please do like, share and subscribe to my channel so that I can make more free videos for all the medical students. Thank you.